Hello and welcome to Hernia Patient Support Group and to our live chat. Tonight we are honoured to be joined by Professor Al Windsor, who's going to talk to us about the importance of shared decision making in hernia surgery. So welcome, Al, and thank you ever so much for giving up your time to talk with us tonight. This webinar is being recorded and it will be available to view on YouTube at a later date. If anybody has any questions, then please use the chat function and we can discuss your points shortly. So I'll share decision making. It's a relatively new thing. Can you tell us a little bit about this and what is the history behind it?
Yeah, well, first and foremost, thanks very much for inviting me. It's, as you know, a topic that's very dear to my heart and something I feel and believe in very firmly. And it is an odd journey, isn't it? We've talked about this in the past, and I remember going back, not that many, but a few years back, working. I won't mention where or with who. Um, but really, shared decision making was just not. There was no decision making. Patients would come into the outpatients department. In fact, there was one outpatients, and I was mentioning to you that there were no chairs in outpatients, so that the patients were in and out really quickly. Because if you had them sit down, they would start to talk. And so it went from that, and clearly that was totally unsatisfactory. But I'm not sure there was ever a voice at that stage. And so how did it sort of evolve? And I guess it probably, and we were again talking about it just earlier, it's probably 2015 to 2020, something like that. Things began to move towards, whatever shared decision making. Well, I guess in the early days, it was more like informed consent. It was, making sure that the patients were given plenty of information about their surgery. And I think there were one or two, for me, there were one or two key issues that really changed things. And again, I know you've spoken to the lady concerned, but Nadine Montgomery and the Montgomery ruling in the Supreme Court, which was all about a young lady who was given no advice about, and she was about to have a baby. She was short of stature, as they described it, with a diabetic child. And she was very concerned, understandably, that she wasn't going to be big enough to deliver this child by vaginal delivery. The obstetrician concerned felt that it wasn't in her best interest to be told the risks, because if she was told the risks, she would make the wrong decision. Well, in fact, there was no decision to be made. And tragically, the baby did get stuck and obviously had cerebral palsy and all of that. And that was probably the real beginning of it. And that was when people started to think, well, actually, and in fact, the Supreme Court, as you know, talked about, the doctor is no longer the sole arbiter of decision making, that they are obliged to give advice to the patient, or at least give information to the patient that might materially affect any decision making. And so that was a huge change, I think, that now we weren't there in an advisory capacity, as it were. We were there to facilitate decision making. And I think the tragedy of it, in a way, was that not many people listened to that. And there were lots of things that came after it to say, actually, and the Department of Health were concerned about it, that they really didn't think that the surgeons and the surgical fraternity had taken that as seriously as they should do. And then, of course, there was the famous Victoria Derbyshire programme, not necessarily all about meshes, and all about shared decision making, but just about the fact that we weren't giving the right information to the patients, that we were hiding behind all of this, both industry and the doctors. And then I think the final bit was the Cumberledge report in 2020, when Baroness Cumberledge really took us to task as surgeons and what have you, saying that we really weren't listening to the patients and their problems with their outcome, that they were cast aside in favour of us just carrying on with what we were doing. And I think those were the three things for me that really began it. And then obviously the Royal College of Surgeons weighed in with a very, very carefully crafted directive on how you should be taking consent. And again, quite a wordy document, and difficult under NHS circumstances to fulfil that, but incredibly important. So that's probably the background.
Yeah, I always think that it should be a partnership now between surgeon and patient, whereas patients played their part and surgeons played their part, and together hernias can be repaired. I was like you, I didn't really have access to shared decision making when I had my hernia repair, and I think it's all about empowering the patient now. We have to let patients know that they have choices.
Yeah.
They things are done with them and not to them.
Yep. Yes, I like that. I like that. And I think that the patients themselves are demonstrating that, aren't they? Um,
Yes.
and I have to say, if you think about abdominal reconstruction, hernia repairing, pre 21, perhaps 2021, it was the sort of changes and the development of it as a specialty was all driven by technique. We were all really interested in component separations, and we wanted to do minimally invasive, and we wanted to do this, that, and the other. And it was a surgical thing that drove it. And I think what's driving it now is patients actually, and you will know as a patient that actually when you get called for your appointment, we know from looking at Google Hits and all the rest of it that most patients will have looked up A, the person they're going to go and see, and B, the procedure that they're going to have. And I think the statistics are that if you look at global searches for healthcare issues, that hernia beats cancer, beats hip replacement at the moment. People are there's enough out there to say that there are
Mm.
choices here. And therefore, people are already making those choices themselves by actually looking up and being informed before they even get to the doctors. I mean, that was nothing, things like that didn't happen 20 years
No,
ago.
it didn't.
It just didn't happen.
Not at all. Not at all. So, we always, within the support group, try to encourage patients to prepare for their initial consultations because obviously with the NHS, time is limited. So the more prepared patients are, the better the consultation will be, the more productive it will be. Um, do you think that patients should do that have that bit of knowledge before, or is it a dangerous thing to know?
No, I can't. No, it's an interesting one, isn't it? That a little bit of knowledge can be a dangerous thing.
Yeah,
But I think patients, if now we've got to accept that there are going to be patients that actually don't want that,
no,
and there are enough patients out there that still believe in the old doctor-patient relationship, and maybe it's an age thing, and maybe it's just the way they feel about it. So I think in all that we discussed this evening, there are a group of patients who are very happy to be advised, and they will come along with that, and there's nothing wrong with that. But I would agree with you that I would encourage patients to take a look and to inform themselves as much as they can to start with. Beware on the internet, as we all know, there is an awful lot of false news. There's an awful lot of scaremongering, and the further you go with Google, the more you go down that sort of
yes.
rabbit
There's
hole. But
there's a lot of
you have a wonderful bit of software, don't you, that patients can.
we
I didn't know about, I'm embarrassed to say, until fairly recently. And I think I've done it, and I've pretended I was a patient,
right.
been onto it. And I
It's
think it's a super bit of software.
that's the Pret. Yes, that's something that is pretty new. It's only just been launched, but patients are finding that really useful. So the patient enters their information and it will ask questions based on the patient's hernia, what type of hernia it is, and their experience of hernia. And at the end of it, it will suggest a list of questions to then go away and ask the surgeon. And we always said there's no such thing as a silly question. If it's important to the patient, it must be important to the surgeon. There's only silly answers.
Mm. No.
Um, that somebody once asked me what would I do because their surgeon had said to them that they should just trust him. They didn't really need to know the answer to the questions. They should just trust. And he said to me, "What would I do?" I said, "I'd run."
I think that's right. I think that there's lots of things in patient relationships with doctors that you have to just be mindful of, aren't they? I always worry about doctor surgeons who never want to ask for another opinion.
Yes,
That and it's as if it's sort of emasculating, and it's as if it's something that it's an admission of inability or admission. And I think that if you can't, if and what's the worst that can happen? You run out of time, and so you schedule some more time if that really is what you need to do. And I think we've got to the stage, perhaps with lots of patients, that if they're unhappy, they shouldn't. And bearing in mind, what we're talking about here is hernia surgery, hugely important, and nobody's going to question that. But hernia surgery, and we've talked about this a lot before, is a quality of life operation
Yes.
in an elective form. Now, it can be an emergency operation, the rest of it. So it's very different. If you're sitting in front of your oncology surgeon and you need a cancer operation, that's a totally different theme. I still think there's a huge amount of information that needs to exchange and understanding.
Mhm.
And there's no question, as we know, that the more the patients know about what's going to happen, the more likely they are to recover well because they are prepared, that whole enhanced recovery and all the rest of it. But I think in an elective situation, when you've got time to make that decision, I mean, after all, we've got time to prehabilitate patients and all of that. So there's plenty of time in most instances. So rather than being rushed into a decision, if the patient is unhappy, then there's nothing wrong. And I know once there's always that fear, isn't there? You've got your appointment, and they're pretty rare events. And if you waste that, and you may never get back. But I still think that you need to be strong as a patient in a way, and it's the patients need to help us drive the system rather than the system driving what goes on. And so I agree with you. I think if you're unhappy with what's going on and somebody's not answering the questions, I'm not sure you want that individual to be looking after you.
No, I'm okay if the surgeon says to me, I don't know the answer, but then I will find out and get back to you. But to just ignore a question, no, I'm not okay with that.
No, I agree. I think that and I yes, and I would wholeheartedly agree that there are times when we don't know, and rather than making it up, it's much.
Yes.
And I'm sure patients, as a patient, I'm sure you would feel more reassured if I were to say I don't know, rather than obviously make something up and say, listen,
Yes.
I don't know the answer to that, but I'm very happy to look into it. And if I can't help with that, then we can find there will be somebody that knows. And I think being honest with patients first and foremost has to be the right thing. That's the whole point of the shared decision making. You're being honest.
Yeah, I think also patients as patients, we have to be realistic about what is achievable with our hernia. So it's a case for you as a surgeon to manage our expectations. So in a way, we have to have that discussion, don't we? So you know what I'm expecting from surgery, and I know what you're going to be able to achieve.
Yeah, and that goes back to that sort of information that once the patient knows what the goals are and what we're trying to achieve, then the likelihood is that comfort, that knowledge does improve recovery. We know that whole business about enhanced recovery, the most of what happens in enhanced
Yes.
recovery is actually that pre-information, that explaining to the patient what the pathway might look like, what will happen when they're in the hospital, what are you going to expect at the end of all of this. And also, if we can only achieve so much quality of life, and if we're not improving quality of life, or at least if the patient feels actually what you're telling me you can achieve is not sufficient for me to move from where I am at the moment. And I have quite a number of patients who are on long-term follow-up. This rather watch and wait. Now, again, you have to be mindful of hernias getting bigger, and they need to understand that the window of opportunity may close, and so we have to be careful. But I have a number of patients who have often had multiple previous operations, so they're recurrent problems. They are fully aware of the things that can go wrong, and therefore they almost come into it too informed almost. But
Yes.
and there's nothing wrong with them sort of saying, I mean, I sometimes meet them once every 6 months and say, nothing much has changed with a hernia. How are you? Nothing much has changed with what I'm going to be able to achieve. Where does that leave us? How do you feel about this? And then it's up to them if they wish to go down the surgical route. We can go through that discussion if they wish to stay where they are. And actually, their quality of life, they're managing that quality of life. They don't want to risk that quality of life. Nothing wrong with that as well.
No, I think we had that chat earlier, didn't we? Where I'd been to this conference where a surgeon had said that every patient walks through the door expecting surgery, but I don't think they do. And I think patients have the right to say, well, actually, watchful waiting is a valid option. Can we discuss this and, help me through the watchful waiting? Let's have surgery when it's a bit more convenient for me.
Yeah, and I think that's perfectly reasonable. I think it's the other way around. And a very good friend of mine who was a surgeon in Nottingham always used to say, give some fabulous talks on abdominal reconstruction. And the onus was very much on the surgeon. His expression was always that surgeons are one-trick ponies, and that if you give them a surgical solution to a problem, they will opt for an operation. So I think it's the other way round. And I
Right.
think as a rule, it's surgeons are, why do we become surgeons? Because we like doing operations. And I do think there's an age thing in this as well. And I do think that you mature with age. And there's a lovely expression, isn't there? You need to know when, good surgeons know when to operate, better surgeons know when not to operate.
Not,
That's
yes,
something
yes.
that comes with experience, it comes with time, no longer. And again, we all go through those phases of wanting to take on the really complicated stuff because that's again the surgical ego. That's what drives us sometimes, and we need people like that. And I've been that sort of person over the years who's taken on some complicated stuff. But you also need to understand in the background again, and that's the communication with the patient, isn't it? On occasions, the big fancy operation might actually maybe good fun, and it may be great for you as the one
Yeah, but
complaining, but it might not be the right thing for the patient.
that's it. Somebody once said to me, all hernias potentially can be fixed, which doesn't mean to say that they should all be fixed.
No.
There's a time to step back.
I think the other thing when you get it's down to that sort of the nutshell there is that these aren't right and wrong decisions.
No.
And we're never going to always get it right. But there are choices. And as long as those choices are informed by all of the information that we can hand over, then, and you gave it, it is a lovely expression and something you mentioned before. It's a lack of regret at the end of it. So even if you have that discussion and you go through it all and all of the options are laid on the table and there's an opportunity to go away and think about it, to come back and rediscuss it, the decision is taken that yes, we're going to go ahead with an operation. And when that operation goes through, if there are complications at the end of it, because the patient has been involved in that decision making, there is a tendency to have a lack of decision regret,
Hmm.
which is a massively important. And again, it doesn't offload our responsibility as the surgeon, but it just helps everybody understand that we really did discuss this. We really went into this in detail. It was a good decision taken when we took it. It was the right decision at the time. On reflection, it wasn't, but it's easy in hindsight. And so there's that lack of regret, I think, is hugely important.
I agree with that. I mean, I obviously you know my story. I have issues following my surgery. I had decisional regret because there was no information given to me, and I became a very angry patient. I think if we have that decision and things do happen, when you've built up that trust and confidence and with your surgeon, and there is that relationship between you, you've been through the shared decision making, it must be easier because in a way because you've got somebody on your side, and that's the one thing that I missed is having that one person on my side to help me through the next stage.
Yeah,
I always think that a surgeon's responsibility to the patient finishes when the patient no longer needs them. So
yeah, I agree with
anyway,
that.
there we go. So when do you think patients should do the consent process?
Uh-huh. So yeah, and again, I think that, I think it's changing, isn't it? And I
Yes.
think unfortunately it's changing. There are good bits to that change, and I think coming in there are going to be some bad bits to the change. I think the good bits are that I think there is a recognition, and I mean, I talk about this and lecture about this quite a lot, and I think if you speak to most surgeons, particularly in the abdominal wall world, and I think it is quite a fraternal, it's quite a family. They call it the hernia family, and I think
Yes.
there is a great deal of wanting to get this right, knowing that
Mhm.
for years and years and years, hernias were stuck on the end of the list and nobody really cared about them, but actually they're very important. So I think that the idea that you can do it all in one sitting and just have a chat to the patient and sign the consent form and be done with it, I just don't think that can happen. And again, we're not talking about an emergency or urgent surgery.
No, no,
So I think there needs to be a conversational piece with the patient and about all of those things, and we could perhaps talk about it in a minute. How far do you go with all the different types of mesh and all the different types of operations? How in depth do you want to get? But I think there needs to be a conversational piece. That's what I try and do, and I think there needs to be an informational piece where you actually give the patient something, and a good patient information leaflet, well written. And I think there are good ones, and most of them are the personal intellectual property of the surgeons. There are some not so good ones out there because I don't think so that may be something we ought to think, if we had a really good patient information, the generalities of it. So I think there's a conversational piece, an informational piece. And I think those two then come together. And I was fortunate in the latter part of my career in the private sector being able to have time to do this. But we then used to have a telephone consultation with the big cases before they came to the hospital. And we did take consent on the day because physically that's when we did it. But we'd done all of the consent process before. And in fact, the discussion piece, the informational piece, and the checking that everything was all right had all well been done, a week, 2 weeks, 3 weeks, 4 weeks before. So the consent itself, the signing of the bit of paper, which is probably the least important bit of it all, it's documenting all the discussions you had previously that's important, actually happened on the day. So I think that's where I would like to see it go. And I know you're going to be asking me a question about what about just signing consent on the day? That can't be right. And I recognize that there are huge limitations in the NHS, that it's an incredibly difficult place to be working at the moment. But I don't think we should compromise on what we know to be right just because it's easier. Somehow we have to find a way around that.
Yeah, I mean, we've seen a rise in the hot clinics where patients aren't being offered the option of being able to see or speak to their surgeon before the day of the operation. And I have some sort of concern over that because the NHS might say, oh, but it's only an inguinal hernia. It's a common thing, but it's a big deal to the patient to have somebody just open them up and repair that hernia. And there has to be trust and confidence, and that only comes by talking to the person who's going to do the repair.
Yeah, it's a really difficult one, isn't it? And
You can sort of see both sides, and I understand why the NHS are pushing the hot clinics to sort of get the waiting list down. But at the other side, like you said, do we compromise on what's right for the patient?
yeah, and it's a very difficult one, and I'm not sure. I'm not sure I could honestly give an opinion. Just like you, I think that you've got to recognise there's 8.5 million people on the waiting list. A lot of those patients have got hernias because they've
Mm.
been sort of drifted to the bottom of the list. And maybe the thing is, and again, this comes back to what we said right at the very beginning almost, was the fact that there will be groups of patients who are comfortable with that. That actually, that so long as somebody's had a discussion with them, so long as they feel comfortable at the hospital with the surgical team or whatever, that they're so keen to have their hernia repaired that
Hmm.
actually they're comfortable with that whole process.
Absolutely.
And that then in effect, if there was a way of filtering those people out and getting them sorted and out of the way, that's great. But then there must be some other people who really, really don't want to do that. And they'll be the people that perhaps need a little bit more. There'll be people with comorbidities. There'll be people who possibly need a slightly different approach, and to be rushed through again, maybe, spend the time that we've got, the limited time that we've got looking after the patients that need that or feel they need it. I don't know. Tough one,
It
Jackie.
is a tough one, but I do think that for the patients who it isn't okay for, that they do want to meet the surgeon beforehand, then it's okay for them to say no. Um,
And
and I want to see the surgeon and just delay the hernia repair if necessary.
Yeah, and that's when strong willpower, and being I think there are ways to approach that, aren't there? That rather than getting cross and angry about it, which sometimes is you've been so frustrated by the whole process right from the very beginning that you I think it's sort of gentle determination. This is not right for me. I don't want to do this,
Yeah, yeah.
and finding a way around it. Tough, and because often these patients then get going lost in the system. That oh, well, they did, we called you, we asked you for an operation, you didn't turn up. So that's the important thing. Don't not turn up. Make sure that you express that issue long
Yes,
before.
yes, absolutely. Make sure that you say no, it's not okay for me. I want to see the surgeon. Send me another appointment, please.
And I think we have to acknowledge, and I have to acknowledge that it always very easy me sitting here on a
Yes,
webinar saying
absolutely.
that. I do understand that you may just have that one bite at the cherry, and sometimes you want to go grab that. Um,
Yeah.
but I think if you're really uncomfortable with it, and there are places you can go to argue the point, I think you're right. I think be strong, and be strong. If it's not right for you, then you have to be as strong as you can.
Yeah, absolutely. So what about these discussions? I know we've mentioned the Victoria Derbyshire Show and the Cumberledge report, and we do have people who want their hernia repaired without mesh, and that's their prerogative. And I understand that, but not every surgeon can do that, and I think we have to accept that as patients. Do you agree?
Yeah, and I think yes, you're right. And I think once again, it's all about information, isn't it? So,
Yes.
we in the who are informed because that's what we do for a living, and
Mhm.
involved in it. We know that mesh repair of hernias, if we're talking about most hernias, but ventral hernias, inguinal hernias, mesh repair of hernias appears to be the right thing to do. It supporting that mesh, but there are ways and means of doing inguinal hernias in particular without mesh. Um,
Mhm.
it's interesting to note that actually, if you look at the volume of material that is left behind, if you do a mesh-free repair, there's still quite a lot of material, and depending on how you do it. But so it's not without plastic, if this
No,
buzzword at the moment. Um, but I agree with you. There aren't huge numbers of people that really do mesh-free inguinal hernia repairs, and therefore, I think information, and if that's something that you really feel very strongly about, then it's seeking out and having to find the individuals that will do that for you. There's nothing worse than somebody having a go at a
no,
mesh-free repair when they don't do that as a for.
no. If that's what you want, you must really do your homework, use the choose and book system and have a look round.
And they're there,
Um,
they're out there, and they're out there, and not advertising, I mean, but they're available. You can find them because that's what they do, and that's where they set their stall out. And there are people out there.
Absolutely. Patients are entitled to their opinion, but it doesn't mean to say that if the surgeon doesn't agree with that, that they have to do what the patient wants. I understand that a surgeon isn't going to do an operation if they don't feel that it's something that they can is going to be successful.
Yeah, and nor should they. And I think that's the two-way thing, isn't it? Once we get down to shared
Absolutely.
decision making, we've got to make sure that the surgeon's comfortable doing all of this as well.
Yes, absolutely.
And I think the other thing that sometimes we forget is that we base surgeons and the medical profession loves to base their decision making on randomized clinical trials.
Mm.
So if you have a whole load of patients that have one thing and a whole load of patients that have the other thing, what turns out to be the best? And you will know the famous study, and for people out there listening, the Lewandike study was published in 2000. It was comparing sutured repair of incisional midline hernias versus mesh repair, and showed that there was a 3 times increased risk of getting a recurrence if you just use sutured repair. But with clever modern, not necessarily modern, but people understanding statistics now, and when you actually apply stringent statistics to those things, they're not very robust, some of those trials, and often it's dependent upon the numbers of patients that were included in the trial and everything else. So we do base a lot of what we do on figures, on numbers, on trial data, but sometimes that trial data might not be quite as good as we think it is. And so those discussions need to be had with patients as well. There are also, as you know, dozens of different types of mesh now, and understanding the difference between synthetic meshes, absorbable meshes, biological meshes, new generation biological meshes, that there's a whole thing there that needs to be, and it doesn't have to be done in a complicated way. It can be done in a fairly straightforward way. But I do think understanding what your options are, not necessarily for inguinals, and I think that's probably not true for inguinals, although it's increasingly becoming true. There are a group of patients who we wonder whether we should be putting plastic mesh in, young people in particular.
Mm.
Um, and so again, understanding all of that is part and parcel of making those decisions about whether or not I want a mesh or what type of mesh I want. And patients, if that's the depth and the understanding they want to have, and they really feel and they've looked into it, I think that's very important. For the first time ever, I've had patients who walked into the clinic and said, as an almost an opening line, I don't want to have mesh. You're not putting plastic in me. And that's a complete change from 10 years ago.
Yes,
They've
yes,
obviously
yes.
heard and listened to it. But again, we need the conversation.
We have to have that conversation, and I always say to people, it's not necessarily who's what they're implanting, although you should ask the surgeon what material they're going to use and the benefits of that for you as against a different product. But it's who's using it as well that you need to be careful of,
Yeah. And where they're putting it, as we
where
know.
they're putting it
Actually,
and who's using it.
yeah. And no, I agree. And again, how do you have that conversation with patients? And there must be a point at which there is an advisory component to that, isn't it? That here's all the various options. What do you think? And the patient then looks at you, oh, I don't. So then you start to say, well, actually, in your particular situation, I think it would be very reasonable to consider using this.
Yes, yeah,
Quite interesting work, though, isn't it? Coming from a chap called Paul Zotek, who's a well-known hernia surgeon from America, who has been very involved in shared decision making. And Paul and I've been on webinars like this in the past. But he runs private practice, so again, a slightly different situation to the NHS. But he gives patients choices, and he talks about these permanent meshes, the synthetic meshes, about absorbable meshes, and about some of the newer meshes. And he finds that if you present that data, then many of the patients will choose some of the newer meshes because
yeah,
there are cost implications. And Jackie, we have to understand that. But I think that,
absolutely.
that's the way the world is moving. And
Mhm,
also this idea that it's just the cost of the piece of mesh at the time of the operation. But what about if things begin to go wrong later on down the line, and having those decisions? So it is
mhm.
a much more complicated, probably,
It
process
is, it's
than
not,
we've been led to
it's
believe.
not a simple decision, is it? It's not an easy thing. I liked it, what Eric Pauli once said, didn't he, that patients aren't one mesh fits all. So again, it's having that discussion with your surgeon. What are you expecting from surgery? How are you experiencing your hernia?
Yeah.
And then making the decision. I don't like it when a patient says, "Oh, I'm going to go and see this surgeon. This is the mesh he uses," before they even go and see the surgeon.
Yeah.
Because how do they know that's going to be the right product for that patient?
And it is tailoring, isn't it? I mean, there isn't one,
Yes,
so there isn't, I suppose that's true of many operations, but they're all different. Hernia is just is an all-encompassing word for a particular pathology, but patients are different, their sizes are different, their size of the
absolutely.
hernias are different, their comorbidities are different, their expectations are different, all the things we've said. So that there needs to be a tailoring of this. You need to think about, and again, that idea that I always do, that always worries me when
Yes,
surgeons
yes,
always do.
yes.
I'm sure that's the right thing to always do.
No.
Do the right thing, not always do the thing that you do.
So when we talk about patients on, we're not all the same. Obviously, we're not all the same size, and I can say that because I'm a big girl. It's better to do the prehabilitation beforehand and have that discussion with your surgeon about maybe losing a little bit of weight, stopping smoking, stopping drinking, getting as healthy as possible before your operation.
Yeah, I mean, just overwhelmingly, yes.
Yes,
That is so,
absolutely.
so important. And I think it is frustrating, isn't it? You got to the surgeon, all you want to do, you're fed up with a hernia, all you want
Yes,
to get the hernia fixed. But the evidence is, and we talked about evidence a little bit, but the evidence is overwhelming in favor of reducing your weight, controlling your diabetes, and stopping smoking at a base, just at as the basics of it.
absolutely.
Getting
So,
fit. You don't have to go, you don't have to be a triathlete, but walking, if you can get out there and do your 5,000 steps a day before you come in for the operation, makes a massive difference in terms of your recovery.
and
So
also going out doing that walk on a day like this when it's cold and frosty, it's good for your mental health as well.
yeah, all that preparation. No, very important. And Todd Henneford, who's a very famous hernia surgeon from the US, and he was once asked at a meeting about, well, what happens if the patients don't lose the weight? They come, and I think it's important that you don't just send the patients. So surgeons shouldn't just be sending people away. They should be
No,
following them closely to make sure that they.
that should still be the partnership where you're supported
Absolutely.
through
Um,
this bit.
and so what happens then, Todd, if you've asked the patient to lose weight, stop smoking, and get their diabetes sorted out, and they come back to your clinic and say, well, I couldn't lose the weight, and well, I did slow down on the smoking. I've halved the amount of smoking that I do, but I'm still drinking the fizzy drinks, and my diabetes is all out of control. And he said, well, I used to say to them, he said, well, out of from A to, or 1 to 5 or A to E, you've given me about a grade C effort there in terms of preparing yourself for the operation. So I'm very comfortable with going to the operating theatre and giving you my grade C attempt at fixing your hernia. How do you feel about that? And of course, the first, "Well, what do you mean a grade C attempt?" So, why, you've not put any effort in. I'm just gonna, I'll do a bit slapdash. So, how important is it to get that right? And he has an app, as you know, which shows
Absolutely. I was going to say that,
you can see it there,
yes.
physically, as for every point of weight that you
Mm.
lose, a kilogram of weight that you lose, or a BMI point that you lose, how significantly it reduces your complication rate. For
Yes.
every point of your HbA1c that comes down. Stopping smoking, the plastic surgeons have known about that for years.
I
And we,
think that's something patients can download themselves. And, I
okay.
think that'd be a good idea for every surgeon to show the patients the Carolinas app and show them.
I mean, it is, as you know, it is slightly, it's all about money, really. Well, the actual output, but it does show you the reduction in
Yes,
complications, and all they've done is
absolutely.
translate that into how much money would be saved as a result of it. But, and again, you and I know that if most of this is all about wound complications and
Yes,
smoke and all the rest of it, and if you get a wound infection after an operation for a hernia, I mean, that's what drives your recurrence, and you're back to square one. So, if you think about, I'm going to go through this really complicated, possibly complicated operation. I couldn't actually be bothered to lose the weight or stop the smoking beforehand. If I get a wound infection, I'm back to square one. And then re-repairing that
mm,
makes it significantly more difficult the next time round. I mean, it's one of those surgical no-brainers. You've just got to go through that and do what you can.
yes, yeah. But I do think that was said that there's no surgeon should just send you away
Yeah.
and to do it on your own. It still needs to be that partnership to work together.
And I'm
So
not sure we're very good at that, Jackie. I don't think that again, the NHS is a difficult place, but having that, being able to have that conversation, and that can be
mhm,
senior nurses are brilliant at that sort of thing to actually help and cajole and it can be, it doesn't have to be done in an outpatient clinic setting. It can be done in all sorts of other ways, things like this. And I think, us improving that prehabilitation has got to be very important.
absolutely. And I think in the UK, if a patient does need to get healthier for surgery, there are schemes available where they're entitled to, is it 12 weeks free exercise and the diet support through
Yeah.
their GPs?
Through their GPs. And again, difficult to get to, and often the sort of things that sometimes GPs don't want to endorse because it's added expense and all the rest of it. But it's there, and I think if it is there in your region, that's something that you need to be able to chase after.
Yes, utilize it and try and insist on it
Yeah.
because it will help in the long run. So we do have a couple of questions here. So, is there a difference in the information you provide for a primary hernia versus a recurrent hernia? I imagine the choice of material might become more important in the case of recurrence.
Yeah, really good question. And whoever asked it, absolutely right. That it depends on where the hernia is and what the hernia is. But in principle, your best chance to get a good repair and a good lasting repair is the first time you do the operation.
Yes,
As soon as you've had a recurrence, then the tissue planes where you've been operating are disrupted, and it's more difficult, therefore, to do it after that. And in the inguinal region, you can imagine, depends where the mesh was put, but if if you did it with keyhole surgery, once it goes wrong, it's more difficult to then do it with keyhole surgery. Then you have to think about doing the recurrence as an open repair, and then you're kind of done. Knowing what we just said is that each time you have a recurrence, the more likely that, you're more likely to get a recurrence afterwards. So it is absolutely the right time to get it right is the first time, and that's pertinent to everything we've been discussing. But yes, so sometimes, and it depends on why it went wrong and why it recurred, and it may well be that the materials you might wish to use the second time round and the approach to the hernia second time round might be different. Not always, but it might be different. And in fact, there's another thing. If you've had a recurrence and your surgeon's going to bash away and just do the same thing they did the last time, yeah, again, you just wonder whether that's, the
the
right
right
thing to
surgery.
do. And maybe that's the time to think, possibly I need to seek out someone who might think around this. And oftentimes, for recurrent hernias, there is a difference on how you might approach them. Not always. So, listen to your surgeon, but sometimes, we see stories where people have had the same operation 4 or 5 times, and it's just come back and come back and come back. And you wonder when they're going to realize that doing that operation is not the right thing to do. Do something different, think differently.
Yeah,
Go on, second, go and have a second opinion. It's
And
not what.
that's the thing, isn't it? I was going to my next point to you that it's okay to ask for a second opinion. And also, if it is going to be a recurrence hernia, maybe ask the surgeon how many recurrences they deal with. Are they experienced in recurrence? Because, like you say, if they're going to do the same operation again and again and again, it's not going to work, and every recurrence is going to be harder to repair.
And I think that is a difficult conversation, isn't it? That patients don't like asking for a second opinion. Most patients, vast majority of patients, have this sort of psyche almost that they want to please the surgeon.
Yes.
And and
Yeah.
and and, you know, I've just been down to the GP for nothing, but I get nervous going to the GP. I get because it's you want to. So I think there is that want to please the doctors that are looking after you, and I think it's sometimes very hard to say, actually, I'm really not. This is not working for me. Is it possible to have a second opinion? Now, I mean, if patients come and ask me for a second opinion, my first response is absolutely. What have I got to lose? What have I got to
Mhm.
lose by sending a patient to a colleague and a friend who I believe is as good or better than me at doing it? So first and foremost, the patients often go across and have the second opinion, and they come back to you and say, "Thank you very much for that. He said exactly what you said he'd say, or she said exactly what you said she'd say, but I still want you to do the operation," which is great because then that is the best scenario. And if they choose to go to your colleague, and you've referred them on there, that's a good thing for the patient, isn't it? Then you've done the right thing. You've got them to the place where they feel comfortable. Why? What I don't understand why you wouldn't send a patient for a second opinion. So I've always believed that if surgeons don't like second opinions, and patients often ask me if they've come to me for a second opinion, I say, "Do you mind if I write to your surgeon?" Ooh, I'm not sure they'd like it if you wrote back and said I'd come here. Well, it's tough. They shouldn't have a
They shouldn't mind.
they shouldn't
They
mind.
should be okay about that because at the end of the day, it's a big thing. We're trusting you with the
Yeah.
best thing, the most important thing we have.
So I think if there's any doubt about your surgeon's willingness to ask for a second opinion or for you to ask for a second opinion, I think that's not a good, that's another one of those things that ought to jangle alarm bells a bit.
I think one of the things what you've just said there is that the surgeons get nervous as well for appointments. For patients, it can be really nerve-wracking sitting in front of a surgeon. So to have that information written down
Yep.
and to have the pre-prepared list of questions is important because my brain just goes to mush when I walk through that door. I can be prepared and I know what questions I want to ask. As soon as I walk through that door, it's gone.
Well, I hope nobody's listening. Well, I know they are, but I had a list going into the GP surgery today. This is the first time I've been to see the GP for about 10, 15 years. But
Yeah,
I'd made a list the night before, just thinking about the things, because there's half a dozen things I needed to talk about. And nothing, it was all trivial, but so no, I get it. I get it. And I think that there's nothing wrong with writing a list and having that list in front of you. Don't we often, as surgeons, when you're the other side of it and patients get the list out, your heart sinks a little bit because sometimes it's a very long list. So try and be a little bit, getting those key points across, not too many questions, but to get the key points across is
yes,
absolutely not a problem at all.
yes. Okay, so our next question is saying, if there is a problem with mesh rejection, is it best to take it out?
Ooh, another really good question. So, and I would, I'm going to ask, clarify the question. The one is, what do we mean by rejection? And that's, in a way, we don't reject meshes. I guess they can get infected and come to the surface, and you can take them out. But rejection, often it's that whole business of the response to the plastics,
Mm,
and this implant illness and things that we don't really understand. Um, so if and again, I suppose to that it is a difficult question, but you've got to think about how much damage are you going to do trying to get the mesh out. And if it is in there and it's been incorporated and it's ingrown and the tissue is round,
yeah,
the scar plate is round it, actually you might cause more trouble
more
trying to get
problem.
it
Yeah,
out than leaving it in. And you know so I think there's a good that's so what you need to do in this situation is if you have a problem like that, you need to go and find somebody who
an
understands
expert.
about problems with meshes and
Yeah.
somebody who's a real expert to
Yes.
ask those questions. Is it going to be relatively easy to get this mesh out? I think if it's infected, that's a very different. So if you're rejecting because you've got an infection in the mesh, that's very different. But if it's these other issues, if you've got some low grade pain or something like that, which is causing a problem, again, taking that mesh out you might end up with more pain and a recurrent hernia than. So that's a difficult decision, and you need to find somebody who really knows what they're dealing with there.
Yeah. I think with mesh rejection, the whole Victoria Derbyshire show, they did a lot of any issues is after surgeries, your body's rejecting it, and it isn't necessarily your body's rejecting the mesh. It can be, like you said, it's an inflammatory reaction. It can just be a number of things. We shouldn't automatically just assume that it's the mesh that's causing the problems.
Yeah, and sometimes it's, certainly in the groins, isn't it? The
Mm.
early pain post inguinal hernia or post groin hernias is often nerve injury.
Yes,
It's nerve entrapment if they've put stitches in and things. And again, there are ways around that. There are people out there who have a specific interest in pain following groin hernia.
yes, and those people are invaluable
Yeah, and don't accept that there's nothing we can do about it. And
because there is.
there are things that can be done,
Hmm.
and going through a sensible and somebody who's got a team that understands those things again is very important. Difficult in the NHS, I accept, but you have to try and fight for those. And often, if you get late problems, it can be the scarring, the shrinkage of the mesh, and things like that cause it. But again, seeking out people who understand and know about those things is very important. But isn't that and that's why we have the discussions going way back to what we were discussing earlier about the different types of meshes, because there are pros and cons of all of these different meshes, and understanding what might be the pros and the cons of a particular one.
Yes. Okay. So our next question says, "This has been the best discussion ever. Thank you very much. Do
Thank you.
you still think that eventual incisional hernia should be repaired with some type of mesh?" My theory on an incisional hernia is we've already had a mesh-free repair.
Yep. I absolutely agree with you, Jack. I think they are different, aren't they? That actually it's a failed repair when you get an incisional.
Yes.
Now, there may be very obvious reasons. It may have been an emergency operation,
Mhm.
you've got a wound infection, and you're always going to get one.
Yes.
But a primary hernia, so a primary ventral hernia, is a if you like, a fascial failure, whereas the other one is a failure of healing, and so
Yeah.
you've declared yourself. So I would agree entirely. I think in an incisional hernia, you really need to think about using some sort of support for your secondary repair.
Yeah.
And then comes the question of what layer to put it in, what operation you're going to do.
Yes.
That's the discussion.
That's the discussion to have. And don't ever be afraid of having that discussion
No, agree.
because you live a long time with decisional regret if you go through it afterwards. So, does anybody else have any other questions for Al tonight? Because I have thoroughly enjoyed this. One more question is with the devolved governments within Scotland and Wales, we do have some people who get concerned about the rights to second opinions, and within those countries, they have to be referred to a certain surgeon. It's very difficult to seek an expert, somebody more experienced. Would you have any advice for people in those countries?
Yeah, it's a difficult one, isn't it? And it's a little bit like the question we had with the hot clinics and things, that you can understand the argument because of limited health resource, and trying to channel patients off a waiting list to get them sorted out. Um, I guess I don't know the rules. Jackie, is the truth. I don't know the real rules, but I think it would be unusual if they insisted on, and that there was no recourse anywhere else. I know there was differences, wasn't there? I never forget when the devolved governments, and literally across the border. I'm born and bred in Worcestershire, so we were fairly, and on one side of the border as
Right,
well,
yes,
you've got different. So I guess my advice would have to be that to really, really understand what the rules are. There's appeal processes, there's ombudsman and all sorts of things. I think you just have to fight your corner if that's something you feel very strongly about. I think the first thing to do is probably accept the fact that go and speak to the surgeon. Go if you are being pushed towards somebody, then there may be a very good reason for that. That may well be that that's the individual that does this sort of work, and often hospitals do that. So I don't think I wouldn't bulk at it to start with. And you know, just
So,
because they happen to be younger than other people doesn't necessarily mean they're worse. Some of them
no,
are.
to be honest, the younger surgeons, they can have a lot more newer
Yeah,
knowledge.
and a little bit of empathy and all of that sort of
Yes,
communicate.
absolutely.
So I
But
think
also, I think it's important that even though you've no choice in the surgeon who you're sent to see, you still have that choice to say no, and you're still entitled to the shared decision making, to
yeah.
everything we've discussed tonight is still your legal right.
And so that's what I would, yes, and I'd agree with that. Go along and see, and go armed with your having been on the preparation app, and go armed with your questions, and see what you get. And you may well be very surprised. If not, then I guess it's a matter of if you're not comfortable saying no, and seeking, a second opinion as best you can. A difficult
Yeah,
one. Again.
absolutely.
I'm not sure I've got the right answer there.
Yeah. Well, I think we're near enough for an hour now, so thank you. It's gone really quick. I've really enjoyed myself tonight.
Me too.
No, and thank you very much for joining us. So this chat will be available to view later on YouTube. And if you've any questions, please let me know, and I'm sure we can help you with that. Oh, well, yes, another message has just said, great chat. One more message here. In the NHS, what would you consider a reasonable waiting time for a patient with an incisional hernia containing bowel, especially when the hernia was caused by previous abdominal surgery earlier this year? I was referred in August and have been told that I may not be seen by the complex abdominal wall reconstruction surgeon until April next year. Is this an acceptable time frame for an urgent referral, and what should I do? Unfortunately, the way the NHS is at the moment, August to April, it seems like a long time, but that's not a huge waiting time at the moment.
So I think so quite important though, and I think what I don't know the story in the case, so it's sometimes difficult to advise. But I think the things to watch out for is simple things like when you lie flat, does the hernia go flat?
Yes,
When you lie flat, the hernia goes flat. Then there isn't a huge concern about that. Yes, the hernia will get bigger, and that 6 months is a reasonable window. I think if it ever gets out, stuck out, and gets tender and all the rest of it, then clearly you need to go and seek urgent advice for it. Um, in the meantime, all of those things we discussed about getting as fit as you can, don't waste that 6 months.
nope, nope.
Go
Start to
and
prepare for the,
start with it.
yes,
Absolutely.
start to prepare as soon as possible. Speak to your GP. Have a good binder, good support
Yeah.
garment.
Put it on the right way. Don't put it on when you're standing up. Put it on when you're lying down so that it's flat and then travels when you stand up if you can.
If you can, or we have the a lot of people find the vests a lot better because
Yeah,
they lift the hernia from underneath and use the
pull it
straps
up.
for support. I'm
I
glad
think
you said that about putting the binder on because not a lot of surgeons know how to put them
know how to
on.
put the binders on. And I do think the other thing is that, and it's a bizarre thing, isn't it? If you've got quite a big, and you can feel your own defect, you can feel
Yes,
your own hernia if
yeah.
you lie flat, you can feel where the edges are. If it's quite a big defect, be reassured. Big defects don't tend to get things stuck. If it's the very small ones are safe, the very big ones are safe. It's the ones that are,
The
sort of people
middle-sized ones that can be a bit.
I think that time frame is probably, and the fact that you're going to be referred to a complex abdominal wall team is a massive bonus because sometimes that doesn't happen. So yeah, I think you're right. I think it's a long time. Don't waste the time. If you get any concerns, if any of the things we discussed just then happen, then you need to seek advice sooner.
Yeah. There's another question about we talked about if things go wrong and there are nerve damage, what treatments are there available? Um, it's things like the nerve block injections, the steroids. There is some people using Botox at the moment, isn't there, to help with nerve
Yeah,
pain?
and there are some very clever people who can identify the nerves that are causing the problem, and sometimes you can, and sometimes having no sensation is better than having that nasty sensation. So
Yes,
I think trying to find your way to somebody that understands those things is very important. It may not be nerve injury, in which case if it's just mesh shrinkage, then there's not a great deal you can do about it. But having those conversations and seeking, and it's a bit of a
it's trial and error.
It is trial and error a little bit, and sometimes we know that a group of inguinal hernia patients will have chronic long-term pain, but that should have been, again, decision regret. That
Discuss.
should have been discussed with you beforehand, because that's a
Yes.
real and important feature in inguinal hernia repair.
Okay, the lady with the incisional hernia has said thank you. She's reasonably fit and healthy, just awkward. Again, a good support garment would help with that. With surgery, I always think it's like running a marathon, and the more you're prepared, the more you get out of it. So,
Yeah, absolutely.
there we go. And one last comment is thank you. Absolutely invaluable advice. It's been so helpful.
Brilliant.
So thank you, Al. I think that's been a really successful chat tonight, and I've really enjoyed it. Enjoy the rest of your evening, and hope to speak to you soon.
Becky, thanks very much. Yeah, speak
Thank
to
you very much. Thank you,
you.
everybody. Take care. Bye bye.